So that is one reason why what I was discussing about this slide, that we should try to keep the lens as far posterior, as far behind the endothelium, as far away from the endothelium as possible. And the question again comes that what age is the ideal age for implantation for doing a scleral fixation? Because you are fixing a lens, you are not placing a lens wherein you can do a lens exchange or anything. So it's advisable that because 99% of growth occurs, or growth of the eyeball occurs at the end of 3 years. So maybe we can wait for 1 more year, and 4 years probably is a good cutoff beyond which we can do a scleral fixation of IOL, and that's what I keep as a cutoff. And so far I haven't got any significant refractive surprise, and the results are quite good in these cases. What is more important is that or the other modality is the suture fixation of a posterior chamber IOL. Now this is an example of an intrascleral haptic fixation of IOL. Now this is a child wherein what I do is that I have a slightly modified technique. I mark the sclera at 1.5 and 3 millimeter positions, and then make 2 radial incisions between these 2 points, and then do a lamellar dissection between these, and then extend beyond the second incision, so that you have a intrascleral groove adjacent to the flap that you are creating by this lamellar dissection. So you have a flap here, and then a groove adjacent to it. The same thing is done on the other side, and then normally I use a AC maintainer for doing this. Stab incision is made at the scleral bed, and a multi-piece IOL, it is implanted through the this small incision, 2.8 millimeter incision. The tip of the haptic is held with a lens fixing forceps, and you keep injecting and you keep pulling the haptic simultaneously. So the haptic is out and lens is there. Then the second haptic is held, and that is also exteriorized. And now you have the haptic exteriorized, so you tuck it into the groove on both sides. This is the haptic which is being tucked into the groove. You don't have to mark it because I do a lamellar dissection with a crescent, so it's very easy to tuck it in, and it goes and very nicely sticks to the collagen of sclera, so that's not an issue. And then we place fibrin glue on both sides. And it's always advisable in children to put a suture, even if your incision is small. In adults you can still manage without a suture, but in children you should put a suture here. Then this is a technique wherein suture has been used, the standard technique. So here what I normally do is, after creating a flap on both sides, I just make a groove. I don't make a flap in the sclera, I just make a groove on both sides. So after tying the knots, I just slip the knot into the groove and keep a large, slightly longer proline end outside, so that it lies flat on the sclera. And for this, since it's a rigid IOL which is basically meant for suture fixation with an eyelet in the haptic, so we have to make a large incision. But initially, just for putting the proline, you may make a smaller incision, and you can enlarge it later. So this is a specially designed IOL with an eyelet in the haptic, and we just tie knots, multiple knots around the haptic on both sides. I normally don't do railroad. What I do is I just take it out from the main incision after inserting it through the groove, and then tie knots around the haptic, and then exteriorize. The same thing is done on the other side, and then once you tie knots on both the sides, you place the IOL behind the iris. The second needle is out. Now the IOL is just being placed behind the iris. There's so much of light coming from that area that it's difficult to see. And then as Dr. Suvira was also mentioning, that we need to titrate the tightness of suture. So one knot is tied on both sides first, and then you pass multiple knots, because you can titrate the tightness by just tying one knot on both sides. And then once you see that the tightness is appropriate and the IOL is centered, we can put more knots and then close the conjunctiva. Now, we just performed a study and compared the stability of the IOL by doing the intrascleral haptic fixation and by suture technique. And this is the amount of pseudophycodenosis that we got in sutured, because you are just tying at one area on both sides. So see, with the movement of eyeball, this is a UBM that is being done. With movement of eyeball, the lens is moving quite a lot. It's almost touching the iris. So the risk of pigment release is quite high in such cases. While in a intrascleral haptic fixated ones, wherein the haptic was fixed, you can see with the movement of eye, the lens is almost in its position. It's not moving quite significantly. So the pseudophycodenosis is more seen with the sutured IOLs, because you are just tying knots at one position. So the lens is still, slightly, it keeps moving with the movement of eyeball. But when you are fixing a segment of haptic, then it is more rock solid and there is hardly any pseudophycodenosis. Now, this is one case wherein after trauma, after doing a glued IOL, the one haptic got decentered, got slipped out of the original position, and the IOL was decentered. So we just try to refix it. It's simple to refix it. What you have to do in this part, it was already visible. So in this area, you have to create, just open up the conjunctiva and then create a flap again. By a similar technique, if it's early post-op, sometimes you can open up the same flap, but many times it's difficult because adhesion is quite strong. So it's always better to have a clean bed rather than having a ragged bed by trying to detach it. So we always try to dissect. Then with the help of another instrument, you just by handshake technique, you hold the haptic, and then the other lens fixing forceps holds it at its tip, and then you can bring it. So this is what is being tried here. So first, since the haptic is going behind, so wherever you are seeing, you can just hold it and then bring it towards the center and hold the haptic, tip of the haptic, and then exteriorize it. And once it's exteriorized, the same technique, you place it again into the groove and then put fibrin glue, and the lens remains centered. So even after, although the lens doesn't decenter, it's quite rock solid. We have done keratoplasties, we have done vitreoretinal surgeries after fixing lens by this technique. But if somebody suffers a trauma, then there may be a risk of decentration. If there is one haptic decentration, you can just hold it simply by a very simple technique and then refix it. Thank you very much.